All right, cardiovascular system. So our zebra cartoon today is just warning you to be careful about what you put on social media. You never know who's watching. All right. So to start out, we're going to have we're going to listen to a little clip of Sapolsky's video on cardiovascular, and then we'll dig into what happens with stress in your vascular system.
One answer comes from a colony of captive macaque monkeys near Winston-Salem, North Carolina.
People think of stress as something that keeps them up at night or something that makes them yell at their kids, but when you ask me, what is stress? I say, look at it. It's this huge plaque in this artery. That's what stress is.
For 2 decades, Dr. Carol Shively has been studying the arteries of macaques. Like baboons and British civil servants, these primates organize themselves into distinctly hierarchical groups and subject one another to social stress. Stress hormones can trigger an intense negative cardiovascular response, a pounding heart, and increased blood pressure. So if stress follows rank, would the cardiovascular system of a high-ranking macaque, call him a primate CEO, be different from his subordinate? When Shively looked at the arteries of a dominant monkey, one with little history of stress, its arteries were clean. But a subordinate monkey's arteries told a grim tale.
A subordinate artery has lots more atherosclerosis built up inside it than a dominant artery is.
Stress and the resulting flood of hormones had increased blood pressure, damaging artery walls, making them repositories for plaque.
So now when you feel threatened, your arteries don't expand and your heart muscle doesn't get more blood, and that can lead to a heart attack. This is not an abstract concept. It's not something that maybe someday you should do something about. You need to attend to it today because it's affecting the way your body functions. And stress today will affect your health tomorrow and for years to come.
Social and psychological stress, whether macaque, human, or baboon, can clog our arteries, restrict blood flow, jeopardize the health of our heart. And that's just the beginning of stress's deadly curse.
Alright. So, what happens when we have the stress response? So we know that sympathetic nervous system activity is going to increase heart rate, right, through norepinephrine release on the heart. That norepinephrine is acting through those beta-ergic receptors, to increase cyclic AMP, which opens these L-type calcium channels. That's going to cause the heart to constrict, right, to contract. In addition to speeding up contractions in the heart, we're also going to change blood pressure. So we're going to constrict the veins, which is going to help get deoxygenated blood, used up blood, faster back to the heart so that it can get oxygenated in the lungs again. And the opposite happens for the arteries. So once the blood gets oxygenated, the arteries are going to dilate so that the blood can flow back to the muscles to get energy to the brain and to the muscles faster. So we have this sort of biphasic effect, constriction of the veins and dilation of the arteries. We are also, in general, constricting blood flow to areas that don't matter, like the gut, to get blood flow to the legs and the arms and the brain. Secondarily, we also have effects not on the cardiovascular system per se, but it does impact the cardiovascular system in terms of the kidneys are going to reabsorb water, and they're going to water back into the system, and that, by adding more fluid back into the blood supply, is going to also increase blood pressure because we're adding more volume into the system. And the bladder, anything in the bladder, so the kidneys are filtering things, right? And they're helping maintain our salt, water, and electrolyte balance in the body. And once the water's taken out, or waste products are taken out, then it's sent to the bladder, and the bladder basically holds the waste until we excrete it, until we urinate. So kidneys are sort of bi-directional, right? So they can take stuff out, but they can also put stuff back in. Whereas the bladder, once it gets to the bladder, then it's just waste product, right? And so Sapolsky talks in the chapter that was for today about that. And there's sort of an interesting thing about why do we have bladders? It's sort of so if you didn't read that, it's pretty interesting. Okay, so hypertension, high blood pressure, chronic high blood pressure. When we have high blood pressure, it causes smaller vessels, smaller blood vessels, to increase their control, because now we're doing this, especially intermittent stress, that we're doing this constricting and dilating. And so just like if you were to exercise your biceps, right, you're going to, as you're using them chronically, contracting them, then they're going to build up more muscle, right? Same thing happens with these blood vessels. They start to thicken. They increase their muscle thickness. That in turn makes it harder for them to constrict and dilate. And so when it's now harder for them to constrict or dilate, it's this vicious cycle, right? They go back to here. So now we have higher blood pressure because it's harder to maintain that, and then sort of this vicious cycle back and forth. When we're constricting the veins to get that blood back to the heart, the blood comes back into the heart through the left ventricle. And as it comes in that left ventricle, it basically is like this fire hose slamming into the muscle of the left ventricle, and that can damage that muscle. And so you can get an increased size, you get this hypertrophy or increased size of the left ventricle, and then that makes it sort of lopsided, and we get this, you can get irregular heartbeats, right, where the left side is not able to work as well as the right side. Another important thing that we'll talk about stroke today in the brain, but there's a particular type of stroke that's not in the brain that's particularly damaging by chronic stress, which is when we damage the blood supply to the heart. So the heart itself needs oxygen and needs a blood supply to keep beating. So those coronary arteries are the arteries of the heart. And so if we have lack of supply there, then that can be really damaging to that heart tissue, and we can start to have parts of the heart tissues die. We have infarcts, just like the stroke is.
When it's talking about increased size of the left ventricle, is it talking about the ventricle itself or the muscle around the ventricle? So is the space that the blood is in bigger or smaller?
Bigger. And the muscle, but the surrounding is muscle. So the muscle gets bigger, but the space gets bigger, right? And so in addition to having problems with changes in the size of the heart, we can also have, as the video showed, problems with blockage, with plaques, with inflammation that can occur. So how does that exactly occur? When you have constricted blood flow, this LDL, which is a type of cholesterol, accumulates. And when this LDL accumulates, it attracts immune cells and triggers an inflammatory response. So now that blood vessel becomes more constricted because it's becoming inflamed, the tissue's getting bigger, right? And macrophages are going to come in. And those macrophages are coming in to get rid of the LDL. But when they devour or consume the LDL, they form these things called foam cells. And then those foam cells become lodged on the wall, and eventually sort of fatty streak or covering develops over that and becomes very fibrous and clings to the side of the artery. And that's what you were seeing when she was showing the pictures of the atherosclerosis of the macaque arteries. Right? You can kind of see there's a layer, there were the foam cells, and then there's this fibrous layer, like a new wall almost, and we've now constricted or changed the size of those arteries. This is just another sort of depiction of that shows, okay, we have LDL build up, macrophages come in and form these foam cells. The foam cells then come lodged and create that fatty streak, and now we've constricted blood flow in that area. All right, so as I mentioned, a myocardial infarct or ischemia of the coronary arteries is what causes heart attacks often. Okay? So what exactly is a heart attack? A heart attack is where there's some problem where the heart stops beating, or that it's so irregular that we can't get blood supply to the brain. So if we have a plaque that builds up in a coronary artery, then that's going to reduce blood flow to part of the ventricle or the heart muscle, and that heart muscle can actually die. So what happens if you now have this plaque that is built up in a coronary artery and you add in a stressor? What's going to happen?
Does it increase the blood pressure and it
Yep.
moves the plaque further down?
Okay, that's one thing that can happen is if the increase in blood pressure, this blood that can't get through here now dislodges the plaque, then that can be very deadly, because that plaque can then go float down into a smaller blood vessel, because blood vessels get smaller and smaller into capillaries the further you go, and cause a complete blockage, right? Or if it breaks free and makes it out of the system, it can go to your brain and cause a stroke, right? A blockage there. Right? So high blood pressure can, when we have a stressor and we get an increase in blood pressure, that can be very negative. What else happens when we add in a stressor? So how does the high blood pressure happen? Yeah.
The constriction of veins and the dilation of arteries, where there's a clot there that would kind of inhibit or get in the way of that.
Right, and so if we constrict this vein, if this is the only pathway that we have through this coronary artery, and now we constrict it, we're basically closing off blood supply, and at the same time, norepinephrine is doing what to the heart? Telling it to go faster. So it needs more energy, and we're constricting it. So it's like having a stroke in your heart as opposed to in your brain, in an area that needs a lot of energy. Right? So these are very sensitive. This atherosclerosis, particularly of coronary arteries, is very, very sensitive to the effects of stress. So move into the brain, because that's what we really care about. We have these negative effects on the cardiovascular system, but it really impacts the brain. Because remember, the brain is using 25% of your energy needs. Right? So anoxia is what we call the loss of oxygen. So we have a small reservoir, right, of oxygen in our lungs and in our blood supply. But if you stop breathing, or if your heart stops beating, right, then that blood is not moving. And so that oxygen gets used up really quickly, which is why it's so important to know how to do CPR. And because CPR, if somebody has a heart attack or their heart stops, you want to immediately start pumping that blood through their body because there's still oxygenated blood in their lungs, and then oxygen in their lungs and oxygenated blood that can get to the brain. But you have to start right away. All right? So common sources of anoxia besides heart attacks are obviously when you're underwater or drowning, right? That's the cause of death and drowning, and inhalant drug abuse. So people that are using inhalants are, instead of putting oxygen into their blood, are putting chemicals. And not only can those chemicals be very toxic to your brain, but the lack of oxygen is also the leading cause of death for inhalant use. All right, so 10 seconds of anoxia will cause loss of consciousness, right? So your brain can't function in a way to maintain your consciousness. So very soon. 20 seconds of anoxia, you start to get no action potentials in neurons. Neurons start not being able to fire action potentials. So now we've gone from decreased brain activity where you lose consciousness to no brain activity in certain areas. And after 2 to 3 minutes, neurons start dying. So after this 20 seconds to 2 to 3 minutes is long enough for them not to have energy that they start to die. All right, so 3 different types of strokes that we'll talk about. You can have a hemorrhage, intracerebral hemorrhage, where we actually have a rupture. We get blood into the brain. Well, remember, there's a blood-brain barrier because blood's toxic to neurons. And so then that we're going to get an infarct or an area of damage there. 3 different causes of hemorrhages. We'll talk about aneurysms. Aneurysm is where you have sort of a stretching or a bulge of the capillary, and then that bulge can rupture because essentially it's like having a balloon, and you keep blowing the balloon up until the wall gets so thin it just bursts. You can also have congenital malformations called AVMs, and those people, usually they won't be discovered until somebody has a stroke. And they'll go in and go, well, what was this cause? Well, it was this congenital malformation. It wasn't hypertension or anything like that. Although if you have this, it's kind of like a ticking time bomb that you don't know is there, and stress negatively impacts them, right? So hypertension, increasing blood pressure, you can have so much of a hypertension, and we get that rigidity in those small capillaries that the increase in force can actually just burst the capillary. Right? So 3 different ways that we can have blood that gets introduced into the brain. Then you can have an ischemic stroke. Ischemic means it's just a lack of glucose and oxygen. So it's a blockage. There's no actual blood contact with the brain, but there's such a blockage of energy needs that area of the brain then ceases to function and can have anoxia. And it's not just anoxia, we also have glucose, right? And so if we're not able to get glucose into the brain, that's also common. Typically, this is due to atherosclerosis, as we mentioned, or it can also be because of a blood clot that gets dislodged. And so after you have major surgery, they're going to give you blood thinners so that we're trying to keep blood clots from forming in that area where the surgery was. You have surgery on your leg. You don't want a blood clot to break off from the leg and go to your brain. This can be which is thrombosis. Sorry, that's the third kind. So thrombosis is sort of a type of ischemic stroke. It's where ischemic stroke, you have a plaque or some other blockage where we're reducing energy needs. And it can be complete or incomplete. Right? So if it's complete lack of energy, then we're going to get death of the tissue, which is an infarct, an infarction. If it's incomplete, which is going to, obviously, wherever that happens in the brain, you're going to lose that functioning of the brain. If it's incomplete, say we have a plaque that is formed in one of the branches of the middle cerebral artery, right? Then whatever area of the brain that blood supply is going to is going to start to have impaired ability. It's not going to, you're not going to just lose that ability, but it's going to present with sort of odd impaired ability. So if that was going to an area, for instance, that was involved with language, the person may start speaking in an odd way, right? If it's an area that's involved with frontal lobe, they may not be able to make decisions, or their personality may change. They may all of a sudden start becoming emotional for no reason. Right? Yes, Liz?
So when a patient presents like with these symptoms, like impaired, like certain impaired abilities, would it be easier to like diagnose them with like a specific stroke than like other types of strokes?
Other types of strokes like what?
Like the intracerebral hemorrhage.
Yeah, so typically when you get a hemorrhage, it's a pretty massive event. And so often those people lose consciousness, right? When you get an ischemic stroke, they'll often present with these behavioral symptoms that are related to wherever the event is happening in the brain, right? And they may lose consciousness with this, or they may not. All right, so what happens? How do these neurons die? So with ischemia, we get this decreased blood flow to cells in this area. And those cells need oxygen and glucose for the sodium-potassium pump, right? So what does the sodium and potassium pump do in neurons? It restores the resting potential, right? So in the dendrites and soma, it is, restoring from EPSVs and IPSVs. In the axon, it's restoring from the action potential. If we don't restore, if the sodium potassium pump can't do its job, we can't have neural signal. That's why electrical signaling stops. It's because we don't rebuild the forces so we can have another action potential. So the pump is pumping sodium and calcium out. Remember, calcium comes in the axon terminal to cause exocytosis, and there's a pump there to pump the calcium back out so we can have it come back in again, right? And potassium is going to accumulate outside the neuron. Now, the sodium and potassium is bad because that's going to impair electrical signaling, both inputs and outputs. The calcium is bad because calcium, an influx of calcium or too much calcium inside the cell is a trigger for apoptosis. It's going to trigger cell death. All right, so neurons die. Glial cells have to then remove the waste. So glial cells, what do they normally do when they're not dealing with a stroke? What are some of the jobs of glial cells? Neurotransmitter removal, right? So we get rid of neurotransmitter out of the synapse in 3 ways. We can have circulating enzymes that break it down. We can have reuptake by the neuron itself, which obviously is not happening here, right? It's the neuron died. And we have glial cell absorption. And if you remember when I talked about neurotransmitter systems, what was the main way that glutamate gets taken out of the centers? Glial cells, right? So these glial cells are normally absorbing a lot of glutamate, which is the primary excitatory neurotransmitter. When they have to come in and start changing what they're doing now, have to come in and clean up debris, these dead neurons, they dump that glutamate. And that glutamate then can trigger an excitatory response in neighboring cells. Got 3 more markers there. So this is our brain, right? And say we have a small little infarct here of dead tissue. Well, now there's going to be glutamate released in the surrounding area. These cells are then going to get inappropriately stimulated, excited, yet there's a smaller amount of energy left. So if then they die, the infarct is then going to expand, right? And now more glial cells are dumping glutamate. So we get a bigger area, and this is the effect of the penumbra, right? And so when we are adding in that glutamate, we're making the pumps have to work harder in the presence of less energy, right? So this is a very negative effect, right? So we call this spreading from a small initial infarct to a much bigger area of the brain that gets affected, the penumbra. And it's one of the advances in neuroscience that when we understood this, that we started to make a huge push for early detection of strokes and fast treatment of it so that we can block this. Because there's a lot of things we can do to prevent that spreading of the penumbra medically. With hemorrhage, right, we have a primary effect of the toxicity of the blood that's going to immediately cause infarcts. But then, and we're also going to get an edema, so that blood's going to form like a pocket and push out on other cells in the brain, depending on how big the hemorrhage is. And at the same time, wherever that blood was supposed to be going, it's not going there anymore. So that area of the brain is experiencing essentially an ischemic stroke at the same time. So we get the same sort of thing, the same sort of penumbra effect, except you can see how much more serious a hemorrhage is than an ischemic stroke, right? And so they're often, the prognosis is much worse for hemorrhages than for ischemic strokes. All right. We can also have drugs that can produce the same sort of excitotoxicity. So now, if you have a drug that's highly excitatory, like methamphetamine or cocaine can have some of these effects depending on how much you use. You can actually increase the needs of a neuron's energy so much by overstimulating it that you overwhelm the ability, even though there's not a stroke happening, right? There's not a lack of energy, but you over-exceed the energy available. And then if a neuron dies, then we get that same sort of penumbra effect. All right. So I mentioned that calcium is a signal, right, for apoptosis. So in development, we overproduce neurons in the brain. And this allows for variation, allows for connectivity to happen. And when neurons don't receive the appropriate neurotrophic support, they don't make the right connections, we have this programmed cell death that happens because we want those neurons to go away. We make more than we're going to need. The ones that hook up correctly get neurotrophic support, they're fine, they'll stay. The ones that don't hook up properly, we want to get rid of. So we have this innate programmed cell death signal that can happen. Now the problem is if you have inappropriate amounts of calcium because of, say, a stroke, then it can also trigger this natural pathway. It doesn't go away after development, it's still in the cells. So the increase in calcium signals a release of the Diablo protein. So whoever discovered this was like, oh, this is a really bad thing. And the Diablo protein, there's a check and balance system, right? So cells don't want to die inappropriately. So they have these things called inhibitors of apoptosis proteins, these capsases. And normally that's preventing this programmed cell death from happening. But the Diablo protein can disable those and basically unlock the system and then the cell goes through the apoptosis process. In normal development, depending on like where you are in the brain and how many overproduction of neurons there are, you can have as much as 80% of neurons naturally going through this process. So this sort of innate process for normal development can be hijacked in a stroke by having too much calcium present. Or a drug coming in and overstimulating so that we have too much calcium present can also trigger this. All right, so summary of this. So we have strokes caused typically, especially ischemic strokes, typically minimal damage and often temporary, right? So think about the case where we have atherosclerosis and we have a stressor, and that stressor causes the artery to seal off. That's going to create an ischemic stroke. As the stress response is removed, the artery will expand back and blood flow can be restored to that area. So sometimes, depending on the type of ischemic stroke, it may be transient or temporary and not permanent. Now, if it's because of a clot or a plaque, we have to go in and remove that. Or unless it sort of dislodges on its own, or if it's a clot, we can give blood thinners and maybe that will cause the clot to dissolve. It's the secondary effect of overstimulating that really is the devastating thing of strokes, particularly ischemic hemorrhage, as I mentioned, is that. The accumulation of the ions inappropriately because the pumps aren't able to work kills neurons. And when those glial cells come in to clean up, they do what essentially is a sort of protective thing. It's almost like they form a fence or a barrier around the dead area to sort of prevent the stuff from spreading throughout the brain, which is a good thing, right? But then they don't go away, they stay there, which is a bad thing in recovery because now you've erected a fence around this area and it's very hard for other neurons to penetrate or sprout new axons or dendrites to help sort of restore function in that area. So here's the normal astrocyte distribution in the rat. And this is what it looks like after a ischemic stroke. So you can see like the challenges of trying to regrow axons into an area to reform connections in this sort of scar tissue that happens in the brain. Which is initially a protective thing, but then after the event becomes a negative. All right, so what are the treatments for stroke? Well, one, we want to figure out what's the source of the damage and eliminate that. So as I mentioned, if we can have blood thinners, clot-busting drugs, we might have to have surgery to go in and remove a blockage. It's pretty amazing that we have the technology and the tools that we can actually do that and put a catheter in your internal carotid and feed it up into the brain and be able to see and do that. If there's edema pressure, so if we have a hemorrhage, we want to get that blood and that fluid out of there. So they may insert a shunt into the area to drain the fluid out. Secondarily, we want to reduce this, right, the penumbra. And so this is a big focus of research, and we've come up with some pretty good solutions so far. They're not perfect. We can do things like block the effects of glutamate, but with a glutamate antagonist drug. What's the problem with doing that? Yeah.
It would also affect like other areas that are not damaged?
Yeah, we can't. So when we give drugs, they have global effects. They're not site-specific, right? So if we're blocking calcium, we're blocking glutamate, we're increasing GABA to have a more inhibitory effect. All of those things are happening globally throughout the brain, so you have to be very careful about that. When we give a huge glutamate antagonist, we're going to stop activity in the brain, and we don't want to do that. Right? So these are tricky, right? We have to be very careful with how we administer them. Neurotrophins are not currently used as a treatment, but they are a focus of research to see, okay, well, can we flood the brain with neurotrophins that's going to say, hey, don't die. I know you're getting a lot of calcium, but you're in the right place, you're doing the right thing, as a sort of neuroprotective measure. And that's still in an experimental phase. It turns out that one of the most successful treatments for stroke, particularly people who are having big strokes, is to try and reduce brain activity, right? So we may initiate a medically induced coma to reduce the level of brain activity, and then we may cool the body and put someone in a hypothermic condition because that reduces the energy needs, cooling the brain. So you probably heard stories about people that fall through ice in a lake and are trapped underwater for 20, 30 minutes and are resuscitated. That's a long time to have anoxia. Neurons start to die after 2 to 3 minutes, and you're underwater for 20 minutes. How are you not brain dead, right? Because the water is so cold, it slows down the energy needs so much that there's enough available energy in the body that they don't have that massive effect, right? You don't hear about somebody in Orlando, Florida being trapped underwater for 20 minutes and being resuscitated. That doesn't happen because the water's too warm, right? It's the fact that you're in an icy lake that allows that to happen. So actually, we have now, it's not uncommon for ambulances to have hypercooling systems that if they respond to a massive stroke, that they're already cooling the body on the way to the hospital. Right? And they may keep you in this sort of hypothermic state for several days to try and prevent the penumbra from happening. All right, some more specific types of strokes. We can have subarachnoid hemorrhages. This is where you get that pocket of bleeding in between the brain and the arachnoid matter, and so that's going to produce an edema and push down on the part of cortex that is there and cause impairments in that, whatever that cortex functioning is. It can affect any age. It affects more women than men, but if you look at it per age, it's really not gender specific. It's not that women are more at risk. It's just that women live longer than men, and so that risk actually increases the older that you get, the more frail your cardiovascular system gets, and so you see like there's a bigger population of women over 50 than men, and so it looks like it affects women more than men over that age. But if you look like per capita or per number of people alive at that age, it's pretty much the same. There's also, and Sapolsky talks about this in his chapter, and hopefully this is changing, but there have been studies that have shown that there's a difference in care that's often given to women who present with stroke than men. And there's a lot of different reasons that that might happen. One of which is to say that men are, because they don't live as long as women, often if a man has a stroke, his wife is still alive and is probably advocating for care and maybe more extreme care than if the woman is a widow and her husband's already passed away. There's nobody like in that role advocating for her care, right? All right. An aneurysm, you can have these things called, so an unruptured aneurysm is where we get that bulging of the artery where we're going to have a pocket of blood accumulating. And that pocket of blood creates like turbulence. So as the blood's coming through there, it's like a rapids. It's like throwing a rock in a river. If the river doesn't have any rocks, right, or if you think about like a drainage culvert that's concrete, right, the water just flows smoothly through there. If you throw a rock in there, or you take part of it out, you get rapids, right? You get this turbulence in the water, and that's what happens with the blood supply. And that turbulence, like, further carves out that blood vessel and causes this bulge to happen. So treatments for aneurysms. This is what it can look like in a real brain. So here you see the aneurysm right there, this bulge. This is an angiograph where we put a tracer into the blood supply so that we can image it. And so this is sort of what you're seeing in the cartoon side. So there are two different treatments to cure aneurysms. One is to go in and surgically sort of clip it and clip it off there and remove it. And so here we see that that's been done here, where that aneurysm was. We've now clipped it off. This is invasive, so we're going in, we're breaking the blood-brain barrier. But it's a cure, it fixes it. It's like you go into the culvert that has the damage to it and you put concrete back in and make it whole, right? Another way to treat aneurysms that's less invasive is this coil method. So again, here we see an aneurysm. Here you see a catheter that's been inserted up through, fed up into the blood vessel from the neck. And it releases these metal coils into the pocket. And these metal coils essentially, it's like pouring sand into the hole in the culvert. You're basically like filling it up and pushing the blood back out and sealing it off that way. So instead of just putting a clip there, we're filling it with these coils that sort of that push this blood back out. This is less, I mean, it's a fix. Those coils can dislodge, or, I mean, they're not in there permanently like a clip. So when I say the clip's a cure, it means that we've sort of fixed that part of the blood vessel, right? Here we've stopped the problem, but it's not necessarily like as permanent. And usually it's a good solution, but because it's less invasive. Yes, Kate?
So here you fix the aneurysm, so in the sense that there's not turbulence in the blood flow, but you created a clot. So is that, I mean, it just creates different problems, right?
Right. So this is good for small aneurysms that are unlikely to rupture, right? Bigger aneurysms that have a risk of rupture, we want to go in and probably clip them, right? But if it's a small one and we don't have to do neurosurgery, we don't have to go in, disrupt the blood-brain barrier, or all the other invasive things that have to happen with clipping it, then that's a better solution. All right, so as I mentioned with stroke diagnosis, early detection is the key, right? So what are the symptoms of stroke? Well, there's a sudden onset. This doesn't happen gradually, right? There's a rapid onset in absence of other neurological trauma. So somebody starts acting abnormally, and they didn't hit their head, right? They're not using drugs. That's a sign that something's going on neurologically and with the blood supply, right? How do we then, so that's a symptom that gets someone to a hospital. Then once you get to the hospital, how do we effectively diagnose it? Well, they're going to do a neurological exam that's going to do all sorts of different, test all sorts of different areas of the brain to see where is the behavioral deficit. It's going to have memory components, it's going to have motor components, it's going to have balance components, it's going to have speech components, it's going to have decision-making component, all of that stuff is trying to use behavior to identify where. Now we can also do things like look for, if we think it's a hemorrhage, you can do a lumbar puncture, so like a spinal tap, and look for blood in the cerebral spinal fluid, which would tell you that you have a problem. That's pretty invasive. That's really only done if you think if someone's unconscious, right? You can't do the behavioral stuff. You think they had a hemorrhage, we're going to check with lumbar puncture. You can do CT scans or MRIs with dye, as we saw in the other pictures, to look for, to try and identify these problems. Often, though, with an ischemic stroke, you're not really going to see anything on a CT scan or on an MRI, right? Unless it's gotten pretty big already. Things can increase risk. Stress is one of those factors. Hypertension, non-stress-related hypertension, obesity causes hypertension, smoking causes damage to the cardiovascular system. And in terms of prognosis, obviously it depends on where the stroke happens and how serious it is. So one thing about strokes is that no two strokes are the same, right? Where it happens in the brain is unique, and how much damage happens in the brain is unique, right? But overall, if we look at large numbers of people that have strokes, 3/4 of them survive a month, so only about 25% die within the first month. And there's a 60% survival rate at 1 year and 40% at 5 years. Once you've had a stroke, you're at increased risk for additional strokes, because whatever caused that, if it was hypertension, probably isn't going away. We're going to try and treat it with drugs and other things, but, right? And then recovery is going to depend on, again, where it was and how big it was. All right. I'm just going to pull all this up because we're running out of time. But as I mentioned, where it happens, right? If it happens in motor cortex, we're going to get paralysis. If it happens in Broca's area or Wernicke's area, we're going to get language issues, right? If it happens in the frontal lobe, we're going to have deficits with things that are going on in the frontal lobe. One of the things that I wanted to mention is that after someone has a major stroke, often they can have things called vasospasms, which is where the blood vessel essentially has like a seizure, has a spasm because of the inflammation and the other, like sort of the trauma that has happened to that blood vessel. And so people after major strokes are often admitted to the NICU for a week or 2 weeks to monitor this. As I mentioned, they may be put in a medically induced coma to reduce the blood needs, energy needs of the brain. I just wanted to, we talked about this in the first week of class. The major blood supply to the brain is the carotid arteries. The major output of the carotid arteries is the middle cerebral artery. And so the middle cerebral artery is covering posterior cerebral artery, anterior cerebral artery, but all of this area cortex is middle cerebral artery. And this is where we tend to see effects of stroke, right? Because of the way blood comes up into that circle of Willis from the carotid artery, this is sort of the most vulnerable. It's pretty rare you get stroke and blindness, right? The internal part, the medial part of the brain, so usually it's the lateral surface, because here we have the medial part being anterior cerebral artery and posterior, which comes from the vertebral artery, which is much smaller than the internal carotid. All right, last thing we made. All these things. Aphasias, I'm sure you've already talked about aphasias in other classes. Broca's aphasia, problems with language production. Wernicke's aphasia, problems with language comprehension. If you have conductive aphasia, the pathway in between the two, right, can also produce problems. We don't have a class on Monday, Martin Luther King Day. I encourage you to, there's lots of opportunities to get engaged on campus for Martin Luther King Day. I encourage you to do that. We have a paper for Wednesday that is going to be looking at experimentally the effects of stroke. I just wanted to go over sort of the, real quick, what they're doing is they're taking a piece of optic nerve out. They're hooking an electrode to one end and recording from the other end so that they can artificially, this bump here is an artificial stimulation of the nerve, and normally we get a big response on the other end, right? We stimulate electricity, we have action potentials, come over here and summate, and then they're going to do an oxygen glucose deprivation to mimic the stroke, and now with no oxygen or glucose, we get no signaling, even though we get the stimulus. And then we'll look at recovery time. So I just want to explain that method so you're good on the tape. All right, have a good weekend, extended weekend, be safe.